Good afternoon, everyone. BJ Medical College and Hospital welcomes all the participants for today's RDLS session. Today's topic is scaling up services at LAC, LAC Plus centers, and the speaker is Dr. Kamlesh Upadhyay. Dr. Kamlesh Upadhyay, sir, is the professor and head with the Department of Medicine and the program director of Center of Excellence in HIV Care at BJ Medical College and Civil Hospital, Ahmedabad. He has actively contributed in developing the treatment protocols for diseases like COVID-19, mucormycosis, CCHFV, leptospirosis, etc. He has more than 35 noteworthy papers published in national and international journals. We welcome you, sir, for today's session and request you to start the session.
जी नमस्कार. Thank you, ma'am, for the kind introduction. Dear participants, आप सभी को शरद पूर्णिमा की शुभकामनाएं. माता जी का पर्व चल रहा है, तो आपके घर में भी आपकी माता जी, आपकी धर्मपत्नी जी, बेटी, बहन सभी को भी हमारा सादर नमस्कार. Just coming to the topic, scaling up the services of the Link ART Center and Plus centers. Every state SAC should focus on their clinical load, and accordingly, they should decide for the comfort, for the adherence, for the saving money of the patient. We should work together so that how we can save money of the, and we can save the money and we can increase the comfort. Any patient coming from village to the city area, many times they are afraid, and particularly those who are coming for the first time, they have apprehension. So the concept of Link ART centers, it was started in 2008, is really a very good concept, and we should encourage more such cases, more such center in. Really, they should practice. In Gujarat, there are 59 Link ART centers and 3 plus centers are there. There are CSC, where workload is more, in Patan district, Radhanpur, Tharad in Banaskantha district, and Bardoli in South Gujarat, where we have more cases, so they have been started. I spoke to all this center also, how they are functioning, and one thing is that the treatment initiations at LAC Plus center, it's still not in real practice. I spoke to other officers in the NECO and some of the doctors in the Karnataka also, and Tamil Nadu, Telangana, states where the high number of cases is there, workload is more, they are taking advantage of this Link ART Plus centers, so that time has come to review our situation in Gujarat also, so that how we can increase the comfort of the patient. Today in this lecture will discuss about how the LAC and LAC Plus are functioning, what is linked in, what is linked out, various activities of Nodal ART center, what they have to do, how to maintain the records, how do we report through SOCH, and then various SOP to start ART, how to do follow-up, how to do CD4 and viral load testings at what interval, and lastly, the community ART refill groups, so that the overall transportation of the family or some community groups money can be saved. As we know, Link ART centers were established in 2008, and initially, when a guideline was said that every patient were not put on medicine, so many of the patients were coming late. When the CD4 is less than 200, by the time they had a lot many complications, OIs were there. So the adherence was a problem. To come to the ERT center was a problem. And this concept, if I'm feeling proud that in our center, Dr. Manoj Sevkani was there. Very down to earth man, physician, and he discussed all this issue at the time that how we can improve adherence when the patient is not coming. Either can we go to the patient with the medicine or not? So that was beginning, and then some pilot studies were done, and now across the country the centers are there. If I'm not wrong, there are more than 1,200 such centers are there in the country. Other than the just treatment depot center, they just treatment supplying depots, the quality of the care given by the nursing staff or medical officer or counselor or a lab tech who is really trained in all these things, their commitment, their in-depth knowledge to the medicines, their complications, their side effects, their rapport with the patients, all these factors will definitely improve the outcome of the patients. The patient should feel comfort that, oh, I want to go to this. Today I'm going to the center. That happiness, every month, if he's getting chance to meet our staff member, and that's a real gain of the ART center, linked centers. So the objectives of these centers were to increase the access to the ART, to improve the drug adherence and retention of the cases in the ART centers, to bridge the gap between testing and treatment services of HIV, to integrate the HIV care support and treatment services with the general health system, so that without any stigma, once we are starting LAC plus or LAC center, they are generally in a common district hospital or CSC where LAC plus is started, where patients are going, they will come, they will feel that we are treated at par with the common other patients. So that sense of acceptance also will be beneficial in improvement, in healing of the patient. And through various involvement of the community groups, and to supply the medicines for the family, for MSM groups, for FSWs, or through Vihan, we supply the patients who are bedridden. Then once the patient is getting medicines, he is feeling better, then our aim is that only. Let's put the patient on antiviral drugs. If it's better, his sense of well-being is improved, then let him to come back to the center so that his confidence level also build up. And overall, when one family member is coming to collect the drugs for the 4 or 5 members who are positive, that will reduce the cost of the transportations. And for that small amount of money is going to give lots of support to the family. To start the Link ART center and plus centers, NACO and GSEX, actually state used to take the call. They visit the place, and as per the number of cases, clinical workload, they decides that which centers are really required. And then in that health facilities, the government deputed medical officers will be trained there, the nursing staff, lab tech workers and counselors. They'll be trained to take care of solely the cases of HIV positive. The LAC and LAC plus, the difference in the function is basically at the once the patient is coming to ICTC, register for the first time in any nodals ART center, then his continued treatment for 6 months or so, good adherence, there is no side effect of the drugs, patient is doing well, no OI, no tuberculosis, and such patients, those are stable patients. They can be just every month they have to come for the medicines to a long distance. That can be cut down with the link centers, and there we can provide a treatment from there. The staff is trained, so they will also look into the side effects of the medicines. One important thing I want to highlight here is that at LAC or LAC plus center, the staff should focus on the weight, because we are not doing testing at the link ART centers or plus centers. We may collect the samples and send the samples to the ART at least twice in a year. What is practiced today is every 6 monthly the patients come to the ART center, then sample is taken at the ART center. Guidance says you collect the samples at the link ART center plus, and you can send the samples so that patient doesn't have to come. So the patient is stable, then every 6 monthly follow up at the ART center, so that at least he'll have a looked by the trained doctors. At link ART center plus, the medical officers which are from the government, they are trained, but many times there is a transfer of the government doctor also. It's possible. So repeated training is important, number one. Number two, early identification of the side effect. That is to be that nurse or healthcare workers who is taking care of these patients must be trained for that. That what side effects are common with these medicines. Important thing is a weight. Don't measure the weight once, but compare with the previous month weights. That is important thing. If the weight is increasing, that means viremia part is controlled with the medicines, either first line, second line, third line, whatever it is. Weight is maintaining. That means drugs are effective. If weight is not increasing but remaining static, any patient does not have any symptoms, no other 4S or any other possibility of any OI, in that cases, still the patient can be monitored. And when you refer the patient to ART center at 6 monthly follow-up, at the time, just mention about that this patient's weight is static or decreasing or increasing. Because this will guide you. Oh, patient is having some treatment failure or not. We can clinically judge in this way. So I request all of you to focus on not only the single weight measurement, but serially. We have to prepare a serial every month, whether the weight has increased, static, or decreasing. In a ART Link Plus Center, we can initiate the ART. In our 3 center also, yes, but it is not practical. We are starting the ART in the ART center only. And then once they are stable, we are referring them to the LAC Plus. So practically, they are just like LAC only. They practically. We want to improve the system so that LAC Plus, we can initiate the treatment also. But we can initiate the treatment, but modification, if the patient becomes symptomatic, if you develop any other OI, or if you develop any symptoms of tuberculosis, better to refer the patient to the ART center, let it be seen by the ART center so that they can modify the treatment if required. So basically, at the LAC Link ART center, just it is a supply of the medicines to observe the patient's overall well-being, to monitor the side effects of the medicines, whether the patient is gaining weight properly or not, and every 6 monthly follow-up with the ART center. whereas in LAC plus centers, we can initiate the medicines, but no modification of the medicines at that level. Symptomatic cases, either the LAC or LAC plus, at both the places, they must be timely referred to the patients. Now from LAC or Link Plus center, when they are coming to the ART center, it is known as a linked in. And from ART referred to Link center, it is linked outpatient. And there is a specific protocol. We'll follow that also. These are to setting up the link ART centers. The checklist is there, from space to the manpower, the training of the manpower, availability of the medicines, their how they can stockpiling of the medicine is there, appropriate environment is there or not, laboratory investigations, and along with that CSC where the or district hospital or SDS hospital, when there is a linked ART center is to be prepared, certain basic facility. Then what are the routine testings available there from CBC to LFT, RFT? The basic tests are carried out there or not? Such things are seen when we assign that center as a LAC or LAC plus. So once it is feasible to start the centers with the permission of the GSEC and permission from the NACO, the centers are started. As I told you, to link out, once the patient is registered at the ICTC of the ART center, he started treatment, he is, does not have any routine testing is done, reports are normal, no co-infections, or his condition is good, he's remained stable, regularly in follow-up, adherence is good. Now, the adherence is something I want to address here. Many times, patient adherence is a problem because the treatment center is quite away. So just on the basis of 6 months adherence, we should not much stick to that. If the patient will go from Ahmedabad to Tharad, if he's getting medicine there, the adherence will be more. So even if the patient is not adhering properly, ideally it is written 6 months adherence at the ART center. And then you linked out to patient, you will go to the linked ART center. But if because of the money, if he is not coming to this your center, otherwise no problem. He is tolerating medicine very well. In that cases, we should allow him to go there and take the medicines from that link ART center. That will be better practical approach, because if he remains stick to adherence for 6 months, then patient may not come. If he go to his nearby link ART center, he'll go there, he'll take regular medicines. So these are practical things we should keep in mind. So for the link out patients, either a child or adult patients, he should be stable patient. As we discussed, he may be on first line, second line, or third line. We can refer them. He must be willing to take medicines from that. That is also important thing. And those who are on TPT and completed 3 months on TPT plus stable patient, they should be referred as a linked out patient to the LAC center so that the drugs can be supplied from there. From link ART centers, the treatment can be supplied for maybe 1 month, 2 months, 3 months also. So all these LSCs must maintain the at least 3 months. 3 months. Medicine supply should be maintained. So a number of patients taking treatment from their center multiply with the 3, so that some stockpiling of the medicine should be there, so that in case some drug supply is not hampered, the patient do not remain without medicines. As we discussed, the stable definition is standard, adult or adolescent more than 10 years, and for children more than 2 years of age. Those who are infant or less than newborn having HIV will not refer the patients to LAC. We'll manage them at the ART center level only. So any adult or adolescent more than 10 years of age or any child more than 2 years of age stable on treatment for at least for 6 months, no side effects, no current illness, no OI, or no other medical conditions which require regular monitoring, say diabetes or some cirrhosis or some other conditions where he require other medical management, and they have suppressed viral load and CD4 cell count more than 200, and adherence is more than 95% consecutively for at least 3 months, can be referred to the link center. As I told you, children more than 2 years of age shall be termed as stable. So anybody, any child, newborn or infant, children up to 2 years of age to be managed at the ART center. ART prescriptions and documents for the link. We should provide them the information about the LLC, that you are coming from your, it will be near districts, it will be near your bus stand से आधा किलोमीटर दूर है या 3 किलोमीटर दूर है. So you have to provide the information. You can give the people's name who are working there so that they feel better. Someone is going to receive me in a proper manner. So the information about the center should be given, to whom to meet them straight away. Otherwise, if he'll come to any routine OPD, then he'll be end up in that whole queue. He'll wait in the queue. He'll go to the medical officer. Then he may not be aware. So direct them where they, in which room number they have to go. That must be clearly mentioned to them. Then when he's going, at least send the patient for 1 month. Even when during a linked in time, when the patient is coming for the CD4 testing or viral load testing at every 6 months, at the time also, you supply them 1 month treatment from the ART center. So here also, when the patient is referring out, linked out for the first time, at the time also, at least give 1 month treatment so that during that period he can go there, inquire there, and they can take a subsequent treatment from there. So this is important thing. And at the link ART center, we are not changing any regime at that time. Any patient is having complications with the medicines, they must be referred back, linked in to the ART center. So otherwise, he has to continue the symptom treatment for 6 months. So entry of this reference must be through the source, either linked out or linked in. Regular visit of the ART center at 6 months interval for the viral load and CD4 testing. Everything, every movement of the patient must be entered in the source so that from where the drugs are given. When we are, patient will maintain his original green book with him, and he will bring the white card copy, either Xerox copy or soft copy. He will bring, either he is linked out or linked in. Either he is going from ART center to a link center or link center to ART. Every time he will bring the latest updated white card copy so that the treating doctor can study the card and he can understand what's going on. The white card should be mentioned, everything, and it should be maintained at both the center, ART center and link center. The white card should be maintained so that the data is properly stored. The link ART center should not initiate or modify the ART in any patient at any time, whereas link plus centers can initiate the ART on but do not modify the ART. Practically, again, I'm repeating, we have 3 linked ART plus center, but the practice going on is the ART is still initiated in the ART center, then they are referred to the plus center for treatment collections. But in other part of the country, people have started taking advantage of the linked ART plus centers, so that even for the first time also, they can be registered there, they can start their treatment, they can give their samples at that plus center level, so that they won't come to ART center once even, and they are getting treatment. So those who are having really financial problem, we must adopt this practice in our Gujarat also, and we should when the MBBS is there in the government set up CSC or district hospital. They all are CSC, 3 CSCs are there, the plus centers, where they should now learn to initiate the ART. If required, we can have a separate discussion on the how to initiate the ART also. But if patients are getting benefit, Government of India also wants that our linked ART plus centers should should initiate the ART. We should practice that. So for the benefit of the patients, it will save the money of the patients. So we must start working on that. As I told, referral on ART patients from LAC to nodal center linked in when is returning back in between routinely once every 6 months for the viral load testing and CD4. So twice in a year he will come, and patient should be sent at least 1 or 2 weeks before his ARV refill is due date, so that he is not remaining without medicines. Who requires reference before 6 months? If the TB or major OI is diagnosed or suspected, if there are any major adverse effects of ARV drugs, pregnancy, if it is there, and if required, it is not compulsory. Unstable or unsuppressed viral load who have completed step-up counseling and have 95% adherence for 3 consecutive months. For LAC outside the health facilities, PLHIV who are 4S positive or have any minor OI or adverse effect, etc. So they can be these 5 subgroups can be referred to the ART before 6 months. When the patient is referred back to the nodal center, he or she should be given the following documents. As I told you, its entry should be there through the SOCH, and he must bring his original green book as well as hard or soft copy of white card. Should bring updated copy. Once the patient is coming at the nodal center routinely every 6 monthly, then it should be examined by the clinical review. 4S screening, tuberculosis there or not, viral testing, sample for a CD4 cell, and other investigations if at all required. Drug refill shall be done from the ART center for 1 month. Then, if the treatment needs review or modifications, that also to be taken to be done at the ART center. And he should be given, his white card should be updated with whatever findings, blood reports are there, and the soft copy to be given to him, or Xerox copy should be given to him for his linked ART center. If the patient requires some admission, some co-infection, some other new findings in disease, we are getting many pancreatitis cases also. So if something else is coming in the patients, he requires investigations, then you keep the patient, retain the patient in the ART center, but don't forget to inform the link ART center that patient will be and will let you know once he is coming from here to there. So through the SOCH, exit of the patient from the ART center, again at 6-month interval entry, or after coming, if he requires still admission or intervention or some monitoring at monthly interval at the ART center, the link ART center must be informed through SOCH. The initiation of the ART at the LAC plus center At the LAC, we are not doing, but at the LAC Plus Center, we are doing, we are initiating the ART. So that hospital where plus centers are there, they must have a routine basic test, biochemical test available in the hospital. Biochemical test, X-ray. We have to ensure that patient is having a HIV positive plus other parameters normal. He does not have any other co-infections, no clinical evidence of any opportunistic infections, and such cases may be put on ART center. We can initiate the ART from that center. For follow-up CD4 and viral load center, we can collect the blood at ART plus center and we can send it to the ART center. And for that also, patient may not need to come to ART center. Now, in Gujarat, the practice is different. We are sending the patient every 6 monthly to the ART center, at least for the blood collection. एक बार डॉक्टर देख लेगा. We must, for the sake of the patient, I request all medical officers, all people working in the ART, link center or link plus centers, particularly link plus centers, they again discuss with themselves. If required, we can train again, and they should focus on the side effect of medicines, how to monitor the patients, how to monitor the symptoms of tuberculosis or any other illness. So we can manage the patient. Patient need not to come to the nodal ART center. Baseline instructions are same. What we should do, as if we are doing in ART center, some basic workup, chest X-ray to CBC, ESR, LFT, RFT, we should carry out at the plus center. And if required, they can communicate with the nodal center medical officer also for any query. So if it is manageable with the talk of the two medical officers, one at the link plus center and the ART center medical officers, if they can solve the patient and any query, that will be better. That patient does not have to come to the ART center, and his comfortable level, his trust in our system, it will be more. Initial ART in a classical manner, what we are doing with the other patient ART, same scenario is there. We have to monitor the viral load and CD4 at every 6 months interval. As we do, to whom will refer the patients who cannot be initiated the ART at the LAC plus center can be referred to the nodal center. Will mention in the register the patient will be referred to nodal ART center. Even if the ART is initiated in the link center, link plus center, they must register at the nodal ART center, so that both the center must maintain the record of the patient, what is started, and if the patient requires modifications, refer the patient to ART center, and then regime will be decided by the doctors at the ART center. So initiation at link ART plus center is better, but modification, if the second opinion is taken, then it will be better for the patients. Patient may be referred to the nodal ART center for the following results. As I told you, tuberculosis clinic is suspected or any other OI is suspectable, not manageable with the LAC plus center. For the guidelines, as per guidelines, testing of CD4 and viral load, some treatment failure is likely, patient is not responding, weight is decreasing. We should, oral health of the patient is not improved, some adverse effects are observed, and patient is having poor adherence. and not manageable at Link ART center must be referred to ART center. The recording and reporting at both LAC level, LAC plus level, green book will remain with the patient, and white card must be maintained at both the places. Whenever the patient is linked in or linked out, he must carry the Xerox copy of the white card, either in a soft copy or hard copy. The register of the drug stock to be maintained, and with the pharmacist through the source software, and drug dispensing also, because in between, after 5 months, every 6 months, for 1 month, treatment will be supplied from the ART center. So everything must be maintained and enter in the software, so that we must have continuous data that patient is taking medicines regularly. The HIV register, other laboratory data, TB registers, everything should be well maintained, and note must be there at both the places. As I told you in the beginning, at least 3 months stock should be available at the LAC or LAC plus at any point of time. And that is so as per the number of patients taking treatment from that center, multiply with the 3 months. So that patient will not be deprived of medicine at any point of time. Drugs are generally supplied through the ART center only, and through courier they are reaching the Link ART center or plus center. Will continue the same mechanism what you are practicing over years. It should be reported to the NECO also through the software and through the source. Now, important thing is a community ART refill groups. These are very poor patients. When from the same family, 3 or 4 patients are there, just to collect the drugs, if 4 people has to come, the cost increases. So, from the community or from the family, 1 member can come, even from the neighbor. Neighbor is a patient. So, from that vicinity, that group must be formed so that 1 person can come. That 1 person must be in rotation also. But practically, when husband is going for to earn the something, wife is free, she is coming repeatedly to collect the drugs, and we are supplying them the drugs also. But because husband, so if we'll insist that husband should come in rotation, then again a whole day is wasted. So as far as possible, rotation to be maintained. Otherwise, we see that they get the medicines. These are basically self-help groups for themselves, from the community. So for the family, 1 person can come and collect the drugs. From the neighbors, they can use. Or there can be a common high-risk behavior. FSWs, 1 person will come and collect the drugs. Transgenders, 1 person will come and collect the drugs from the others. Same for the MSM or IVDUs. Vianney also taking sometimes drugs for those who are bedridden patients. And we have to supply the drugs right at the home of the patients. So these are the, in average, in our hospital, University of Ahmedabad, we have a almost 5 such cluster. So 5 people are taking medicines of the 4 or 5 persons in the family. So roughly 20% medicine is collected by only 5 people. So that monies are saved. And that money can be utilized for the nutrition of the patient. So whenever he's coming, we should tell them that आप इस बार अकेले आए हो, 4 लोगों की दवा लेते, तो वो पैसे कहाँ करना है? तो वो आपके घर में जो प्रेग्नेंट लेडी है उसको गुड़ और उसको चिकी खिलाना है, ये बच्चे को खिलाना है. So by diverting money from transportation to nutrition, and that will help in improvement in the outcome also. So this group must be registered, who is coming every time. And every time, suppose one patient is coming and he's collecting the medicine for the 5 family members, we'll take out all card and we'll individually ask them, what will be health condition? Do they have any symptoms of tuberculosis? Do they have any other symptoms? Are they healthy or not? Because weight gain is not there. And at least at 6 months interval, please call them, monitor their health. And if they can come with the nearby, they can go to PSC or something where they can measure the weight also. So if they are coming with a weight, or they can SMS you that, oh, this is my weight. So even weight monitoring at the home will guide us that what the patient's conditions. What is my observation? We know weight there are many dynamics, from available the nutritions to many things. When the patient is put on the medicines, antiretroviral drugs, the weight gain may be there. If that weight gain is not there, it is person remaining state. If it is declining, oh, we can think, oh, it will be a treatment failure. If it is not decreasing or increasing, we can have a look to the viral load is suppressed or not. So the weight is increasing, that's a good sign. We observe that patient is on first line, no weight gain. But on viral load is not under control. If we change to second line drug and the weight gain is there. So such just simple monitoring only weight is, monitoring the weight is important rather than only measuring the weight. वजन करना काफी नहीं है, वजन बढ़ रहा है, घट रहा है या स्टेटिक है, और आपने वायरल के साथ मैच करो, ये करने से आपको ओवरऑल सेंस ऑफ वेलबीइंग पेशेंट का कैसा है ये पूरा देख के आपको तय करना चाहिए. विद जस्ट वेट वी कैन थिंक, वी कैन नॉट स्टैम्प, बट वी कैन थिंक, ओ पेशेंट में शायद ड्रग फेलियर हो सकता है, आई वुड लाइक टू चेक द वायरल लोड, इस बारे में ध्यान रखूंगा. ऐसी बातें हैं. सो दोज हु आर नॉट कमिंग टू द सेंटर और just one person is coming to collect the medicine, ensure take repeatedly detailed history of every card one by one and individually give them proper time so that they are, what is a P and B, patient not brought, what we say. So when patient is not coming, our responsibility increases. So we should ask about the weight, we should ask about the oral conditions, any symptoms of the tuberculosis, 4S, fever, other absent from any work job place, or any other comorbidities are there. Nowadays, with the ARTs, the people are developing NCD, diabetes and blood pressure also. So such group patients must be, whenever they are coming to the hospital, test them for the all. If the weight gain is there, tummy is out, BMI is increasing, in that cases, you please look at the RBS, look at the measure the blood pressure also. And now in many CSC and PSC, we have our CHOs are there, so we can take advantage of them. They can measure, the ASHA worker is there in the family. We can ask them to at least have a RBS measurement with them. We can ask them to measure the blood pressure with them. So again, when the HIV, the patient is HIV, so when the prick is there, oh, there is a risk of transmission also. So we should train them with a calm mind. And the person who is testing in that village, ASHA worker, she must be aware. इसको पहले card दिखाइए, what you are, and then test करिए, because that prick may infect other people. So we should overall keeping in mind, we should treat the patients so that the whole group can be taken care. So our responsibility increases. We should talk to the patients more who has come for the to collect the medicines, and he must be trained properly that next time when you come, I want this many answers. So you must inquire with each individual. Suppose if they are the family members, they may be aware, but if it is nearby Padoshi, neighbor, he may not be aware. So ensure that they come with the proper answer. Where SOPs are same what I discussed. So responsibility of the CRDs are ensure timely pickup of the ARTs from center and refill from all members of group, monitor the adherence of the members, document the same in the relevant tools and registers and the cards, provide peer counseling and adherence to ART, proper nutrition, positive living to the members, verbally screen members of the group of the TB symptoms. This is not the common thing, but if they are comfortable and any of the patient is not doing well, we can observe them on the video call also. If they video call at the, if they have, now mobile is quite common, so we can look at them on video call also. We can observe his conditions, we can talk to them, and we can have some look at the patient. Ensure that generally our experience is very good, that any person who is coming to collect the, when we are providing the medicines to CARG, the adherence is good because it saves the money of the family. And we should promote CARG so that at least they will take medicines. And once they will have a good, because if the viral load is controlled, there is a intermittent infection is not there, they don't have to admit. So it saves lots of money of the family. So the supply of the medicines through care, through CARG is really a very good thing. There are some common interests of the group, MSM or IV drug abusers or FSWs. When they meet there to collect the drugs also, the interaction is there. And it provides sense of well-being. They share about this thing with everybody. So it will build up the confidence. Out of 4 or 5 people, if one is getting complications, they will ask, no, are you taking it in by mouth or not? And in that case, that will be the cause for the vomiting. So with this CARG, the not only drug adherence, but complications also they discuss. And if someone is having complications, they can be brought early to the ART center. So these are all advantages of the CARG, and it's a very good thing. The key points for the whole discussion: all stable PLHIV should be linked through link ART centers based on the consent. Consent is important thing. We have some patients from Rajasthan. I think one other person is there from the Rajasthan also. They still want to continue every month to this center. अरे साहब, we don't want treatment for 3 months. आपको आएंगे, मिलेंगे, आपसे बातें करेंगे. So it goes to my center, healthcare workers, their relationship, their rapport with the patients. They compel them to come and see the darshan करने आते हैं, ऐसे भी बोलते हैं कुछ लोग. So I really compliment the ART center staff where I'm working. It will be the same at your center also. So when patient is coming and saying, I want to come every 1 month, आपसे बातें होगी, आपसे मिलेंगे, आपसे एक ऊर्जा मिलती है, ये सब बातें उनके फैमिली के लिए अच्छा है. सो अल्टीमेटली बात मेरी एक ही बात रहती है कि हमारा एटीट्यूड टू द पेशेंट्स ये ऐसा होना चाहिए कि उसको आने का मन हो. ये हमारे ART सेंटर मंदिर बने, इधर एसोसिएटेड सेंटर है, लैक है, लैक प्लस है, या ART सेंटर है, सब में इंसान का, वहां जो हेल्थ केयर वर्कर बैठा है उसका जो व्यवहार है वही तय करता है और वही प्रोग्राम को सफलता देता है. सो बाकी जैसे वाइट कार्ड की एंट्री, मेंटेनेंस बोथ सेंटर, एंड व्हेनेवर वी लिंक्ड आउट और लिंक्ड इन, जहां जाता है तो हार्ड कॉपी लेके जाए, प्रिंट बुक तो पेशेंट के पास होती है. सो एवरी टाइम स्क्रीनिंग, we are living in an ocean of tuberculosis bacilli. We are, so not only HIV, but all common men, everybody have a risk of HIV tuberculosis lifetime remain. And with the ART, patient is improved, viral is controlled, now he is developing diabetes. Again, diabetes is a risk factor of tuberculosis. So tuberculosis जान नहीं छोड़ता है, तो उसको आप हर बार every 4 symptoms हम बोलते हैं, बार बार इस पे हम फोकस करते हैं. Because one is infective, बाकी के जो घर में क्लस्टर है, बाकी के जो नॉर्मल पीपल है या HIV पॉजिटिव है, they are also high risk for tuberculosis. So यदि एक को हमने इग्नोर किया तो बाकी के 4 पेशेंट घर में हो जाएंगे. So every time we have to stress more and more and more about the symptoms of tuberculosis. So we don't forget the entry to the source, linked in, linked out, drug supply, drugs का quota कितना है, everything must be. Even if you are keeping the patients to the ART center after linked in, that time also we'll inform through the source to the LAC that we have preserved the patient for us. We want to do some testing, we want some CT, we want some MRI. So remain in contact with the link center so that he is also aware. और ये बातें जब पेशेंट बोलता है मुझे पता है आपका एसटी स्कैन हुआ, एक्सरे हुआ, तो आपको कैसे पता? मैं तो आपको मिला नहीं हूँ. तो छोटी बात भी उसके लिए रैपो बढ़ाती है. तो ये छोटी छोटी बातें जो होती हैं, भारत में हम सब लागणी से जीने वाले लोग हैं. तो ये छोटी छोटी बातें एक श्रद्धा, अरे साहब तो मारू ध्यान હું મળ્યો પણ તો ધ્યાન રાખે છે. So just transmission of the data information from ART center to the link center. तो इसका सिटीजन के इसमें ये आया है, ट्यूबरकुलोसिस आया है. तो मुझे पता है आपका गए थे और आपके ब्रेन में ट्यूमर आया. वो ट्यूमर नहीं है, वो टीबी है, वो दवाई से पिघल जाती है. तो एक छोटी बात उसको विश्वास बढ़ाएगा, अरे साहब तो मेरा इतना ध्यान रखते हैं, तो मैं उसकी सब बातें मानूंगा. ये सब बातें करना चाहिए. एंड ऑल इनिशिएशन जो अब गुजरात में भी नहीं हो रहा है, वो अभी हम स्टार्ट करें. एट द लिंक प्लस सेंटर वी शुड इनिशिएट द ट्रीटमेंट. हमारी मेडिकल ऑफिसर की टीम तैयार है. आप जब भी आधी रात को बोले, वी आर देयर टू सर्व यू. हम आपसे बात करेंगे, हमारा मेडिकल ऑफिसर का नंबर शेयर करेंगे. इवन इफ योर सेंटर इज पाटन और पालनपुर, our center of excellence and ART center Ahmedabad doctors, we are ready to answer your questions. But let's start the practice of initiating the ART in Link Plus Center, so that it is a way to strengthen our sub centers, so that पेशेंट का एक भी पैसा बचता है तो उसके पेट में जाएगा खुराक बन के, न्यूट्रिशन बन के. ट्रेनिंग वो सब करते हैं. नोडल्स ART सेंटर वाले ट्रेनिंग करते हैं, मेंटरिंग करते हैं, मॉनिटरिंग करते हैं. वो कंटिन्यू करते रहेंगे. रेगुलर विजिट टू नोडल सेंटर स्टाफ. अभी तो डाको की मीटिंग होती है या कोई भी डिस्ट्रिक्ट की मीटिंग होती है तो अपॉर्चुनिटी मिलती है, एक दूसरे से बात करते रहते हैं. मिलते रहेंगे तो प्यार बढ़ता रहेगा. बातें हैं तो कुछ ना हो तो एक वीडियो कॉन्फ्रेंस रख देना और बातें करिए. ऑडियो का बदले वीडियो से बात कीजिए, वो भी एक वे ऑफ कम्युनिकेशन. द CARGs, as I told you, the refill groups must be promoted. हमारा, मैं तो ऐसा मानता हूँ, मैं SAC को भी यार बोलता हूँ, सुन रहा है कोई तो, आपके सेंटर में कितने CARG है? आप जो मेडल देते हैं ना उसमें क्राइटेरिया रखिए, आपने कितने CARG को प्रमोट किया. इट दिस बी वन ऑफ द क्राइटेरिया, क्योंकि उसका पैसा बचता है और उसका मॉनिटरिंग भी करेंगे. ये करने से पता चलता है कि आज गरीब लोग हैं तो उनका एक एक पैसा हमारे लिए इंपॉर्टेंट. रूटीन वायरल रोड्स प्लस CD4 at least twice in a year we should carry out. And once we are initiating the treatment at the Links Plus Center, ensure that you collect the samples for the viral load and CD4 center, so for CD4 at that Plus Center only, and send the samples. Don't send the patient. You collect the sample, will for any problem or some no response to treatment or some tuberculosis something is suspected, then only send the patient. Otherwise, keep them. We should, as I told you, regular screening of the diabetes, blood pressure, other carcinomas, some psychological issues are there. They must be referred in time, so that there are many helpline number also for the psychiatric problem, mental health. Now with the treatment, our people are living more and more. Many of them are now crossing more than 60 years. So they are coming under geriatric HIV. The din dunai, we may have a geriatric HIV pura group. Once you have geriatric HIV, then they require someone to listen. The problem with the non-HIV geriatric also. So the depression or something are quite common. So in our HIV patient also, if they are geriatric one or routine patients, if they require someone to listen, and there are many mental health issues, we see sometimes suicide also because of some stress. So anybody who is finding in the stress, well, as a doctor we or as a nurse, we should train. If he's remaining aloof, when you're talking to the patient, if he's not eye-to-eye contact is not proper, he's depressed, not responding to your drugs properly, not responding to your questions properly, some event in the death or something in the family, loss of partner, ऐसे सिचुएशन में टेम्परली पेशेंट को एआरटी सेंटर में भेज दीजिए और लेट psychiatrists help if required, let them to treat with them so that at least some mental support is given to this to the patient. So not only physicalness but mentalness also to be kept in mind, where we have to send the patient back to the ART center for consultation of the psychiatrist. And once the drugs are there, we can send the patient back to them. So thank you very much for the patient's hearings. Any questions are there? Most welcome.
थैंक यू सो मच सर. चैट बॉक्स में कोई क्वेश्चंस नहीं है सर. अभी माइक एक्सेस सभी को दिया गया है. किसी के कोई भी सवाल हो तो प्लीज आप अनम्यूट करके सवाल पूछ सकते हैं.
थोड़ी वातो करो तो મને સારું લાગે. આખું આકાશ મને મારું લાગે. આમ મળતા રહે છે પછી મારો ફિલ્ડમાં હું તો ભટકતી આત્મા છું એટલે મારો ફિલ્ડમાં હું તો મળીએ બધા. એક રાજસ્થાન જવાનું બાકી છે હવે. રાજસ્થાન વાળા ભાઈ જરા મોડું બતાવો. આ બધા ગઢ ગિરનારના માણસો ડુંગરથી થોડા દૂર જઈ બેઠા તો તળેટી નામ દઈ બેઠા. આમ આગા આગા નથી બેહો, મોડું બતાવો તો પોતાના લાભ. કંઈક કરો બાપા. मैम थोड़ा गुजराती में चलेगा? हाँ
हाँ सर बिल्कुल.
ये तो मेरा हिंदी है ना, रूपाणी हिंदी है. एनीबॉडी? चलो, होप यू आर देयर.
धन्यवाद उपाध्याय सर, बहुत बहुत धन्यवाद.
बस थैंक यू वेरी मच. नमस्कार. भैया कैमरा बताओ ने, दर्शन थाय भी करो. सबको एक विनती है, जरा अपना मोबाइल कैमरा ऑन कीजिए. या एआरटीसी भरूच के कलेक्टर साहब तो बहुत बड़े अच्छे हैं भाई, जाके मिलो एक बार, हमारे मित्र है. हाँ यस, दीपक भाई नमस्कार. सरस सरस. अमिता मैडम नमस्कार. मैडम राजसमंद से है. ए हाँ શું છે? કોણ બંધ કરે છે? અરે મૂકને માથા. ચાલો, शबनम अंसारी जी, ईशा मोट, किरण भाई का नाम, अनुज शुक्ला जी, सबको नमस्कार. अहमदाबाद आओ तो चाय पीना आना. बस
जरूर
सबको.
सर, जरूर जरूर आएंगे.
हाँ बस. थैंक यू मैम.
Thank you sir. Thank you so much for facilitating this session. Thank you सभी participants को for joining in today. We'll conclude the session now. Katin sir, thank you.
थैंक यू श्वेता जी.
Thank you sir.
बाय बाय.
राजस्थान છે. નાદ વર્ષ